Submitted for your approval. A sonographer sits in a darkened room. His patient, a 76-year-old female, 4 weeks post-celiac and superior mesenteric artery stent placement. Other than cancer, she reports no significant risk factors and denies any post-operative complications or symptoms. Considering her body habitus, lack of complaint, and post-surgical report, you might expect her to have a normal exam. But appearances can be deceiving. Fixes aren't always perfect, and what seems strange to us is simply normal in the twilight zone. Antegrade flow in an artery, in this case the common hepatic artery, is normal and expected. Retrograde flow in the common hepatic artery is abnormal, but usually not shocking. But when you've documented flow going in an antegrade direction, and later in the exam happen to catch a glimpse, just a quick glimpse, of it going the other way, would you recognize it? Would you acknowledge it? When further examination shows antegrade flow, you might tell yourself that you were just seeing things, artifact perhaps, or a tortuous arterial branch from somewhere else. There is, after all, a limited number of hours in a workday, and there are other patients on the schedule. Me? I was pretty sure about what I'd seen. I meant to report it, which meant I had to reproduce it and document it. After all, I didn't want people to think I was crazy. In the end, I wasn't able to reproduce this finding. This finding reproduced itself. It didn't seem to be dependent on deep inhalation or exhalation, and since nothing that I did seemed to be the trigger for this phenomenon, I was only able to document it by watching and waiting for it to happen. There was quite a bit of waiting involved, but I did manage to catch it. And when I did, I knew two things. First, that I was extremely fortunate to have seen and recognized something so random and unusual, antegrade and retrograde common hepatic artery flow during the same examination. And second, I knew that I'd have to present this at a conference. So now that we know what's happening, it leads us to two more questions. First, why is it happening? And the second, how is it happening? The honest and embarrassing answer is, I don't know. I spent so much time just trying to prove it was happening and trying to get my head wrapped around it that it wasn't until later, when the patient had gone, that I realized how much more I should have tried to see. But that's not really a useful answer, so I'm going to give you the next best thing, something that has been colloquially called a scientific wild-ass guess. So let's back up a bit to the surgery. According to the op note, the patient had a stenosis in her celiac artery with velocities over 400 centimeters per second. The location of this stenosis was just beyond the origin of the vessel. A stent was placed in this lesion, and according to the post-stent deployment angiogram, the stenosis was repaired. However, 4 weeks post-op, her follow-up ultrasound showed velocities of 318 centimeters per second in the celiac artery. Evidently, the stenosis is back. 4 weeks might be long enough for restenosis to develop, but I think a more likely explanation is rebound of the original stenosis. This could only happen if the stent has migrated, and I think there may be some evidence of that. Remember that the op note described the stent deployment in the area of the stenosis, just beyond the celiac artery origin. This picture, and several others that I was able to take, made me think that the proximal stent attachment is in the mid-celiac artery. Another reason I think it's possible that the stent migrated is because of the location of the distal stent attachment. Here in this picture, you can see that the distal attachment abuts the T, where the celiac and hepatic arteries diverge. In addition to the rebounding of the original stenosis and the stent migration, there is a third element of bad news, and I think that this is the key to this case. I believe that there is kinking in this vessel. take a look at the angle of the stented distal portion of this artery and the proximal non-stented portion of this artery. Now, compare it to the angle that you see in this picture. It appears that there's some movement of this artery, and when it forms a more acute angle, this is associated with retrograde common hepatic artery flow. So what I think we're seeing here is a celiac artery that contains a stenosis. And as that artery gets moved around by positional changes, respiratory changes, peristalsis, or anything else, it occasionally gets into a position that really mimics a very high-grade stenosis. What happens when a celiac artery has a very high-grade stenosis, or even occludes? Back in 2002, the journal Radiographics had an article which essentially said that if blood can't get through the celiac artery, there are other pathways that can act as collaterals. One of the most common collateral pathways for flow is the pancreatico-duodenal artery. How is this used as a collateral? And why do I think it's being used in this case? Let's take a look at some of the mesenteric artery branches. You can see the celiac and the superior mesenteric artery and a bunch of other web-like interconnected arteries. Not all of them are shown here, but there are a lot of potential collateral pathways. But these are the ones I think we're dealing with. The pancreatico-duodenal artery is a branch off of the SMA. It splits into the posterior and anterior branches. And if you continue to follow them up, you can see that they join the gastroduodenal artery. The gastroduodenal artery is a branch off of the common hepatic artery, and that in turn is a branch off of the celiac axis. Normally, blood would flow antegrade from the gastroduodenal artery into the superior branches of the pancreatico-duodenal arteries, and also antegrade from the superior mesenteric artery branch into the inferior pancreatico-duodenal arteries. Flow from both the superior and inferior branches is then distributed to the spleen and to the gut. But when blood flow through the celiac artery is cut off or reduced to just a trickle, you get less pressure in the arteries which it feeds. This includes the superior pancreatico-duodenal arteries, the gastroduodenal artery, and the common hepatic artery. And that allows flow from the inferior pancreatico-duodenal arteries to push through, flowing retrograde into the superior branches, the gastroduodenal, and back through the common hepatic artery. And that's why and how I think we're getting retrograde flow in the common hepatic artery. So if you ever find yourself in a darkened room, scanning a patient that presents with bizarre findings, go ahead and tell yourself, The Twilight Zone was just a TV show. It was a great TV show, but it was mostly fiction. In real life, there's a reason for everything you're seeing. Look for it. And if you don't find it, at least try to come up with a logical explanation. You might be right. You might be wrong. But I believe that visualizing all the possibilities will help to make you a better sonographer. Thank you.